The recording will be posted on the advisory committee's webpage shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. It is now 2:04 and I call the June 12th joint meeting of, I'm sorry, not joint meeting, the Advisory Committee of Healthcare Stakeholder meeting to order. My name is Rochelle Bogue. I'm the Cost and Transparency Manager, and I would like to give a warm welcome to everyone joining us today. We'll start with a brief overview of the agenda. We'll begin with the roll call, then we'll introduce the new committee chair, Eileen Cody. Next, we'll approve a meeting summary from September 7th, 2023, which is the last time this committee met in a non-joint session. Then committee members will have an opportunity to introduce themselves. Following that, Chair Cody and Liz from Health Management Associates will go over the purpose of the stakeholder committee and review the charter. Then Gary from HMA will lead us through the medical debt policy discussion. And finally, Marty Ross with Healthcare Authority will give us an introduction to the Analytics Support Initiative. We'll then wrap up and adjourn today's meeting. I encourage committee members to ask questions and provide feedback to help facilitate our discussion and recommendations to the cost board. Thank you all again for your time and efforts. Now we'll go through member roll call. I will call members by first name in order listed on the agenda, which is in alphabetical order by last name. Emily.
Hi, everyone. Emily Bryce from Northwest Health Law Advocates. I'm the deputy director there. I use she, her pronouns. I'm also a member of the Fair Health Prices Washington campaign. And Olympic sports, well, gosh, if I were good at sports, I probably wouldn't be a lawyer. So I don't have any sports that I could even consider competing in the Olympics. Thank you.
Thank you, Emily. Patrick. Patrick, are you here?
He's here. He's having audio.
Okay, we'll circle back, Patrick, because it looks like you're here. We just can't hear you. Bob? Bob? Paul F? Okay, Justin?
Hi, everyone. Justin Gill. I'm the president of the Washington State Nurses Association. I also work clinically as an urgent care nurse practitioner for Providence and Everett. This is my first meeting, and I'm looking forward to hearing more and learning more.
Thank you. Welcome, Justin. And I was notified that Dr. Nariman Hishmati will not be joining us today, but he is next on the roll call. So I'll move on to Adrian.
Hi, yes, Adrienne Jones. My pronouns are she, her. I'm new to this advisory board. I am on the Leadership Council for Washington CAN. I am also a graduate student at the Evans School of Public Policy and Governance at the University of Washington. And if I could compete in the Olympics, it would be snowboard cross. I was on a ski team as a child and in my young adult years, so never made it to the Olympics though.
Thank you, Adrienne, and welcome. Jody? Jody? She's here. She is here. I do see her. Okay. Jody, when you get on and you're able to speak, let us know. It looks like we see you. You may just be having audio issues. Louise?
Good afternoon. I'm Louise Kaplan, and I am semi-retired. I am listed in the book as being an associate professor at Washington State University, but I'm actually emeritus faculty, although I do a small amount of work for the College of Nursing still. I practice as a nurse practitioner And I am also on this committee officially as a representative of ARMPs United of Washington State.
And hi, this is Jody Joyce. I'm connected on my mic now. So I'm the CEO of Unity Care, which is a community health center in Bellingham in Whatcom County, Washington. And I'm also here as a representative of the Washington Association of Community Health. And if I was in the Olympics, I would love to do the biathlon because I've always been fascinated by that. But I'm neither a good cross-country skier, and I'm not sure I've ever fired a gun. So I'd have a big learning curve on both ends of that.
Thank you, Jody, and thank you, Louise. Stacy? Stacy, are you here? Okay, Eric? Eric? Vicky? Natalia?
Hi there, Natalia Martinez Kohler. I'm the CFO of Multicare's Behavioral Health Network. I'm an existing member on the committee. And for Olympic sport, it would have to be not anything where I could break something. I tend to be a little bit clumsy. So I'm thinking like rowing. I'm sure that's probably not easy, but rowing would be kind of fun, I think.
Thank you. Sulan?
Hello, my name is Sulan. I use they, them pronouns, and I'm the lead researcher at SEIU 1199 Northwest. I'm so happy to be here with you all. And I also don't have the skills, but if I did have skills, I would do Olympic ice skating.
Great, thank you. Paul S.
Good afternoon, everyone. I'm Paul Schultz. I'm Executive Director of Actuarial Services for Kaiser Permanente of Washington. I'm new to the committee, looking forward to working alongside you all. I've been a semi-competitive curler for nearly 20 years. So while I've never gotten close to the committee or to the Olympics myself, I have competed against Olympians in the past in the winter sport of curling.
Thank you, Paul. Dorothy?
Hello, everyone. Dorothy Teeter, semi-retired, do some policy work, a health policy person, mostly in the state of Washington and at the federal level. I've been on this committee for a while, and I was asked to join as a consumer, having a consumer perspective. So that's been really fun. My most natural Olympic sport would probably be swimming, but the thing that I think would be fun, although I have absolutely no capacity or capability or aptitude for it, would be breakdancing. So I'm looking forward to seeing that as a new Olympic sport this year.
Thank you, Dorothy. Wes?
Hello, this is Wes Waters. I'm the CFO for Molina Healthcare of Washington. I've been on the committee for quite some time and representing health plans in Washington.
Thank you, Wes.
And I guess canoeing would be a good thing to try. So
And I see Patrick now. I don't think he was able to talk earlier. So, Patrick, if you want to introduce yourself.
Thank you. Let's hope the internet connection holds this time. I'm Patrick Connor, Washington State Director for NFIB, or National Organization representing small independent businesses exclusively. And if we're talking about Olympic events, I am perfectly well suited to be a spectator.
Thank you, Patrick, and thank you so much for all your answers and for being here today to all the committee members, and welcome to the new committee members. So now, please join me in welcoming the new chair for the Stakeholder Committee, Eileen Cody. Eileen Cody earned an associate's degree in nursing from the College of St. Mary and a Bachelor of Science degree in nursing from Creighton University. Eileen retired from working at Kaiser Permanente in Seattle for over 40 years. She worked as a neuro rehab nurse, certified in both rehabilitation nursing and multiple sclerosis care, In addition to her work at Kaiser Permanente, Eileen is a founding member of District 1199 Northwest Hospital and Healthcare Employees Union. First appointed and subsequently retained to the House of Representatives in 1994. She served in the 11th District and then the 34th District through 2022. She's dedicated her legislative career to achieving affordable, quality healthcare for all residents of Washington State. Eileen is currently an engaged member of the Healthcare Cost Transparency Board, committed to ensuring healthcare affordability for all Washingtonians. Welcome, Eileen. And if you want to say anything that I didn't already cover, please feel free to jump in.
No, I think that covers it. Most of the people on this call already know me, I believe, for the most part. I have harassed many of them for years. I'll just add that my Olympic sport, I'm wishing that I would do basketball, but if they can't take Caitlin Clark, I know I would never make it. So, but we're both from Iowa. So that's and Iowa's girls basketball, very strong. So anyhow, thanks, and we can move ahead here, everybody, to tab 2. And we will hopefully approve the meeting summary below. I'm going to count on all of you since I was not a member of the committee in September. This is the last time that you all were together as just this committee. As a note, the recording of the last meeting is posted on the webpage for reference. Is there any discussion about the summary or any changes that people would like to make? Do I see any hands? Okay, see none. Is there a motion to approve the minutes?
This is Natalia. I'll put a motion to approve the minutes as written.
Is there a second?
It's Wes Waters. I'll second it.
All right, thank you. So all in favor say aye. Aye.
Aye.
Any opposed? The motion is approved. So now we'll move on to tab 3. Oh, we've already done the committee of these introductions, so I don't think we have to go through that again. Unless anybody has more to add on their descriptor. Okay, but I will just wanted to say that point out that the committee has changed a little bit. What legislature in their infinite wisdom passed legislation this past session to expand the committee and change the name. And the bill added members to represent consumers and purchasers and to round out the perspectives that we've been receiving to be more inclusive of all Washingtonians. And to commemorate this, formation of the newly revised committee, I want to take the time to allow the committee members, well, we already did the introduction, but to have the member roster showing the current committee members, and the staff will update the committee's name to the Advisory Committee of Healthcare Stakeholders. Now we're going to go through the purpose of the stakeholder committee, and with that, we're going to go to this is tab 4, and I'm going to be joined by Liz Arjun from Health Management to go over this with me as a way to anchor the revised committee and make sure that we're all on the same page. We want to go review the purpose of the committee. And as you can see, it is collaboration, representation, and participation. Those are the 3 main themes. And that all this information comes from the charter, which we will go over in a moment. But these are some highlights we wanted to bring to your attention. So can we go to the next slide? All right, the committee already kind of went through this. And here is the charter. And hopefully you all have you should have received a copy of this. You have any questions regarding this? And Liz, did you have anything else you wanted to? Oh, Patrick has a question. Go ahead, Patrick.
Thank you, Chair Cody. I wonder if there's perhaps an oversight under member responsibilities. Taking a look at the fourth bullet. It mentions, I think, all of the former and current stakeholder representative groups. However, it does omit employers or business. So if that's less work for those of us representing those sectors, great. But if it needs to be added, I'm open to that as well.
That sounds like a good addition and a good catch. That's what you're here for, Patrick. So,
Patrick, can you say that again? This is Liz. I'm just making sure that we take that feedback.
You bet, Liz. Under the section headed member responsibilities, I believe it's the fourth bullet where it describes the liaison and feedback loop. It lists, it does not list employers or businesses.
Okay.
But it does list laborers, consumers, and others.
Perfect. Thank you.
good catch. Anything else? And Liz, you didn't have anything to add?
I don't have anything to add.
Okay. So no further questions, then we can move ahead. And Gary with HMA is going to provide us information regarding medical debt and help facilitate that discussion. So all of the committee members, hopefully you'll have a chance to weigh in on this discussion. So Gary.
Thank you, Chair Cody, and it's good to be with you all. The Healthcare Cost Transparency Board at an earlier meeting heard a presentation by Noam Levy at the Kaiser Family Foundation, who has been doing a lot of work over the past year or so on the issue of medical debt. His slides are included in your materials. I'm not going to go through all of his slides, but I do encourage, if you haven't had a chance to look at the recording of the board meeting, to watch his presentation. Very interesting and very compelling. I'm going to very briefly summarize some of the points that he made and then move on to talk a little bit about policies that Washington has in effect now with respect to medical debt, and then encourage a discussion of additional policies that Washington has not adopted, but which have been adopted in some other states that the board is interested in considering and looking at with the possibility of making recommendations with respect to those policies. No decisions having been made yet, but these are areas that they've expressed an interest in. So why does it matter? We all know, the cost of healthcare is high and continuing to increase. And while obviously the main purpose of the cost board is to address policies to try to mitigate the growth of healthcare costs, in the current situation, more and more Washingtonians are hit with a growing portion of out-of-pocket expenses. Over 100 million Americans now have medical debt, which has caused millions of people to skip or postpone needed care and has caused other economic hardships for them and their families. Medical debt in particular impacts Black and low Americans disproportionately to their representation in the general population. And with respect to efforts to collect debt for medical services, 2/3 of hospitals sue patients or take other legal actions, and 2/3 of hospitals report patients with outstanding bills to credit reporting agencies. Those are national figures. Next slide, please. So there are a couple of different aspects to medical debt and medical debt policy. Actually, what's the previous slide? I'm sorry, did I went too fast maybe. Yeah, collections practices. So we've got two issues that we're going to talk about today. One is collections practices by those who are owed a debt for medical services, and the second is charity care. So Washington currently requires a waiting period before medical debt can be sent to a credit reporting agency, but does not prohibit medical debt being reported to a credit reporting agency, as some states do. And actually just yesterday, the Consumer Finance Protection Bureau of the federal government released proposed rule that would ban medical debt to be reported to credit reporting agencies. So that rule will have to go through a comment period, and then if it's finally adopted, that would be federal law. Washington also does not require that low-income and uninsured patients be offered a payment plan if they have a medical debt, as some states do. Next slide, please. So with respect to charity care, Washington requires that larger hospitals, which represent about 80% of beds in the state, provide care with no or discounted out-of-pocket costs to patients. This is kind of a sliding scale. Patients earning from 300% or below of federal poverty up to 400% of the federal poverty level. However, it's not clear to what extent that policy is actually being followed. And recently, the state attorney general settled a case against the Providence system, which required Providence to pay fines, give refunds, and forgive debt for failure to comply with those requirements. In addition, the process for applying for and receiving charity care could be made simpler and easier. Washington does require a waiting period and a screen for eligibility for charity care before a bill is sent to collections, but not before the bill is actually submitted to the patient. 6 states require hospitals to provide a minimum amount of charity care, which Washington does not. Oregon, in particular, has a formula that considers the hospital's revenue and operating margin in determining the minimum amount of charity care that the hospital is required to provide. Next slide, please. So for discussion today, we're interested in hearing what policies you think would be should the board consider making recommendations on to protect patients and consumers with respect to medical debt. Are there some of those policies that you think are particularly you'd like to learn more about and explore more? And are there other policies that I haven't spoken about so far and haven't identified to address medical debt that you would like to discuss?
Adriana, go ahead.
Thank you. Yeah. Are you able to talk a little bit more about the bill at the federal level to prohibit these medical debts going to collections? Can you talk a little bit more about that?
So the Biden administration mentioned some months ago that it was planning on introducing this policy. And just yesterday, the Consumer Financial Protection Bureau issued a proposed rule that would essentially prohibit medical debt from being included on anybody's credit report. So, you know, you have a credit report and it shows your credit card debt and your auto payment and, you know, all of the areas that you have that you know, of indebtedness that you have, and you get a credit score. And the purpose of this is to make sure that medical debt in particular, I think the idea being that unlike using a credit card or buying a car, your medical debt came about as something over which you really didn't have control, right? You know, you had a medical condition, you had to incur services, and you know, that's the cause of the medical debt. So medical debt would no longer be factored in computing your credit score. And the rationale behind this, you know, as I mentioned, you know, but the goal of this is to protect people from having their credit score impacted by this medical debt, which can affect ability to get a loan, the interest rate that's charged in the loan, ability to get a job. I mean, there are all kinds of external things that happen to people if they have a bad credit score. So the idea is to keep medical debt off of that.
Right. Yeah, I understand that. Thank you for that. And Washington is currently not thinking about that kind of policy.
There is no state law prohibiting medical debt to be reported to a credit agency.
Okay. Thank you.
It looks like Louise has her hand up.
Yes, thank you. One of the issues that I find very perplexing and difficult about medical debt is that when people are uninsured, they get charged with the provider, the hospital bills, but somebody who has insurance has to pay or is actually billed on a contracted rate. So the uninsured person might get a bill for, let's just say, an office visit or let's say an ER visit, and the charge was $6,000. But when somebody with insurance gets that bill, then there's a contracted rate. So now that cost is only $4,000. So there's this huge disparity between what someone who's insured and uninsured actually ends up with in terms of the charge, quote unquote. So I'm just wondering how anybody's tried to approach that disparity.
I mean, in terms of legislation or regulation, I'm not aware of efforts. I mean, that is inherent in our fragmented and I don't know what the right adjective to word for our system is, nonsensical system. And in some cases, I mean, I'm reading recently in support of provider doctors who want to directly contract or directly get paid directly by patients, that sometimes the charge to a cash paying patient can be less. So it's just an irrational system.
Yeah, well, that's true, but when it comes to medical debt, it's usually the big hospitals that are going after people, and it's usually bills like ER bills, which are astronomical. You walk in the door, it's like getting in a taxi and the meter goes on immediately.
Right.
But I do think it's an issue that is worthy of some consideration, so that when you have the lowest income people being disproportionately charged,
Higher
then
cost,
of course, then they're of course going to have even worse medical debt. So to me, that's a big issue.
Thank you.
I think Justin was first, so I'll go ahead, Justin.
Thank you. And actually, Louise probably read my mind because she was bringing up kind of the same topic I was going to bring up, which, I think that there is definitely a big disparity between, I think, what healthcare providers or organizations may be billing out, say, for cash pay for an uninsured patient versus what they expect to receive from insurance companies from that contracted rate. And I'm not sure if in the data, if it's possible to kind of differentiate between medical debt for patients that are directly billed from hospitals that may be uninsured versus medical debt associated with patients who are covered through a contracted rate through a payer. Because that may give us more information about whether, the extent of the medical debt and whether it's potentially bloated to the amount that's expected on cash payment versus private insurer or private payer payment.
Yeah, that's a really good point. We can look to see whether we can analyze the data in that way. Thank you.
Now, Emily.
Okay, thank you. Well, I could talk about this subject for a long time, so I'll try to limit myself a bit. I'll just say, of course, medical debt is a pernicious problem, and it is a side effect of the rising healthcare prices that bring us here today, right? So I agree with Louise and others that this is an important area for the cost board to be tracking alongside some of the other core subjects. There are a number of areas that could be improved here. So I'll just name a couple off the top of my head. First, hospital charity care laws that we do have in the state have not yet been fully implemented. We're 2 years past the last statutory update to our charity care laws, and that hasn't been incorporated into rule. Among the topics that we hope will be addressed in DOH rules is the subject of effective screening, as Gary mentioned. Second, there are gaps in hospital charity care, physician services, satellite clinics, many areas that aren't clearly addressed in our existing statutory framework around hospital charity care. Third, we've got the fact that hospital charity care doesn't apply beyond hospitals. Fourth, we've got the fact that interest rates are high, particularly on public debt. Fifth, we've got high limits for garnishment of wages and bank accounts, the ability to really go after all but a very small amount of a person's remaining funds for them to live on. Sixth, the point that we already talked about around cash versus insured rates. And I think all of those topics are important considerations for our state as a whole, and would just kind of maybe point us in the cost board to a couple of important roles that we could play. So first, we have a statutory charge now to have a standing underinsurance survey and an employer trend survey. And I think that gathering data on medical debt at a very granular level for Washington residents is important, and that's something that we can do uniquely in the Healthcare Cost Transparency Board. More than the traditional questions about, have you deferred or delayed care, but also getting deeper to what's on your credit card. What have you, what other strategies have you used to try to pay for your medical debt? Getting to that level of detail and ensuring that our forthcoming surveys on this topic get to that level of detail are going to provide very important data for us. The other piece of information that I think the Cost Transparency Board in particular could provide and really surface and add to this conversation is surfacing the information about the amount of hospital charity care and community benefit that is happening today at a really granular level. So we've got great new data sources coming out from the state on this. A bill from a couple of years ago, 1272, I think, is kicked in, and there's new data there. The Department of Health has charity care reporting, and we're going to have a new OFM report later this year related to this topic as well for nonprofit entities. And I think that all of these pieces of information are data that align with the cost board's kind of core mission, and could be data that could come back to the broader board as a whole to unpack and have some discussion about. So in a nutshell, I think there's a lot to do here as a state. All of it might not be in this body, and so would encourage us to think about what kind of data sources that we can bring to bear to inform that conversation.
And just before I call on Dorothy, I'm just going to piggyback on that. I don't think the charity reports that we have required made a differential between costs and charges, so that their charity reports are probably inflated to just what the charge master, like as Louise was talking about, there are no contracted rates. So that's another thing for us, I think, to throw into the mix, is to try to, if we want to get a real picture of what's happening. So Dorothy, go ahead.
Well, Eileen, you were thinking along the same line I was, which is for this board, I think a key question is, what's the actual impact of bad debt on the prices and not necessarily on the cost of care. So if we've got these artificial numbers in there, my instinct or intuition would be, there shouldn't be such a thing as medical debt in our state, because it's probably overstated. You never collect it anyway. You could take the policy almost that far, but until you get to your point, Eileen, and what Emily was bringing up, what's the data around who is it? How much is it? Is it because of uninsured care? Is it because what makes it up? And we're not collecting it anyway, why even burden people with it? It's sort of a far end perspective, but I think we need to know the data on how it relates to the cost profile in the state.
Patrick?
Thank you, Chair Cody. Emily, you had a lot of great information, but you put it out so quick that I was not able to get all of it. I suspect staff probably has a much better record of that than I do. But if you wouldn't mind, could you maybe send me that list of 6 ideas? I'd like to have a chance to kind of give those some thought before we convene again.
Sure thing. And really, that was just off the top of my head.
That's what I was afraid of.
There are more where that came from for sure. But I do agree that it's really important for this board to think about the state specific data that we can bring to the conversation.
Any other comments? I don't think you're a quiet group, so. Anybody else that hasn't said anything? Okay, well, listen, Marty, I think, is going to take over, right?
Yeah, hi, I'm Marty. I'm a management analyst in the board and commissions unit at HCA. Been here since September, and I work primarily on the analytics support initiative, the collaboration between HCA and Institute for Health Metrics and Evaluation. So next slide, if you could. So going back a little bit, the history of the disease expenditure project. So it began in about 2013. There were previous iterations before that, but it really coalesced as a project in 2013 at IHME. Primarily, the work done at IHME has been around the Global Burden of Disease project, where they're looking at global health in terms of impact on population, very high level across the world. But the DEX project has grown out of some of that methodology, developing it to some of the methods to look at healthcare expenditure just within the United States. And so there's been a variety of different publications, data tools that they've developed over the years. And recently they completed a new update of the estimates where you can actually look at different areas of the US, states down to the county level, and get a sense of how much money is being spent at a disease by disease level. You can see how it's grown, how it's shrunk. And I've got a little link there at the bottom of the report that was sent out. You can peruse it for yourself. But what this represents is a way to interact with the data. Literally millions of different estimates that have been produced at a very granular level to understand where money is being spent in the healthcare sector. Yeah, the interactive visual that they've got together is pretty great. So next slide, please. And the idea is that you can use this tool to, as policymakers to get at the root of what's driving some of the growth in healthcare costs. So there are a number of different ways that you can break up these DEX estimates, because it's built upon a demographic framework where you're breaking the US population into 38 age and sex groups, a disease framework as well, where you're breaking down individual disease. Disease is how much is being spent in single diseases, groups of diseases, and then across where this care is being had. So whether it's outpatient, inpatient, at the dental office, and a lot of good work in terms of pharmaceuticals, a lot of really interesting estimates that can be perused. Now, in terms of who's paying, they break the estimates down between Medicare, Medicaid, the private market, and then very importantly, the out-of-pocket expenses that consumers have to foot the bill for. Temporal framework, this newest group of estimates is built across 10 years of data between 2010 and 2019. But what's newest in this most recent publication that will be coming out later in the year, that's called DEX 3.0, is that rather than just being at the national and state level, they've actually broken down estimates all the way down to the county level. So this is the overall build of the DEX project, how you can slice and dice the data, aggregate it, look at it at granular levels. If you could go to the next slide. So using these estimates, it was this opportunity came about to have a collaboration between HCA and IHME called the Analytic Support Initiative. So briefly, the objective is to develop Washington-specific analyses of cost growth trends to identify specific areas of focus for discussion, additional analysis and development of cost mitigation strategies, and then provide information that will result in actionable recommendations on reducing healthcare cost growth in Washington. This was funded by Gates Ventures and Peterson Center on Healthcare. It funds one policy analyst at HCA and 3 additional researchers at IHME to build out some state-specific analyses. And the timeline has gone forward starting in July of 2023. The first 6 months, we're building the foundation of the work. The next year has been actually performing that work as it's been defined. And then the final 6 months that will be coming up later this year and then into 2025 is formalizing recommendations that might make sense policy-wise regarding some of the estimates that are arrived at. So if you can move to the next slide. And the thought here is that because these estimates are so granular, you can aggregate them in different ways, and they might be of interest to a number of different entities. So certainly because prescription drugs are a cost center that they've been looking at, the Prescription Drug Affordability Board might be interested in specific reports. Because it's broken down by disease, the Department of Health might be interested. But beyond state agencies, there are a number of different opportunities for other entities that might want to take a look at the tools and reports that are created by ASI. So things like NASHP, the BREAK Collaborative, certainly Washington Health Alliance, AARP, a lot of different groups that might be interested in some of the work that's being done. If you could go to the next slide. So I talked about the first 6 months building the foundation. As I was coming on board in September, the work focused finally in December to understand what types of analyses might be produced by ASI. So at the highest level, it's understanding that we want to create state-specific estimates by disease, demographics, all those different breakdowns that we were talking about. And then also produce risk-adjusted and age-adjusted. So to really get a handle on being able to compare different communities, understanding what's driving healthcare costs in the state of Washington. Decomposing those differences across counties and times will really give us a good look at the data. So if you could go to the next slide. And we're in the midst of the second and third groups of 6 months doing the work collaboratively. As I'd mentioned, DEX 3.0, that set of estimates was finally concluded in March. They did update the interactive tool that I listed on that second slide, I think, on the presentation, where you can actually look at down at the county level, state level, where the healthcare costs are happening. And then just last month in May, Dr. Joe Dielman presented to the cost board, May 15th, the preliminary disease expenditures report. So this is the first run report that the cost board is seeing of the work from ASI. And so what we're charged with here in the stakeholder committee and also the data issues committee that will be joining shortly is to review the report, review some of the estimates that he's found, and offer feedback, ways to not just improve this report, but also looking forward to the final report, the updated report that will be coming in the fall and developed into next year before it's finalized. So yeah, that is end of my presentation, but if anybody had any questions, I'd be willing to answer.
Any questions? Oh, there, Dorothy?
Yeah, just a quick one. Thanks for this update. Do you know what the plan is for updating the data? So this is going to be 5 to 10-year-old, 15-year-old data. Are we going to be able to catch us up in terms of this process over the next? Is this a continuous analysis that adds years as the data comes in? I guess is my question.
Absolutely. So one of the first steps that's happening as a part of the ASI is actually folding in data from the APCD, Washington's APCD, the All Payer Claims Database. So that'll actually bring us up to, I think, 2021. Not as recent as we'd like, but yeah, it depends on how late of a refresh we can get on it. But yeah, it'll certainly bring us into the pandemic at least.
Thank you.
Any other questions? No? We're going to hear more in the second half of but when we get into the joint meeting on this. So Rachel?
Thank you for those presentations, Gary and Marty. And that brings us to the end of our meeting today. The recording and summary of this meeting will be posted shortly on our website. Thank you again to all our presenters. Our next stakeholder meeting will be on Wednesday, August 21st. The meeting will continue after this. That's going to be the joint portion. So that'll start at 3 p.m. We'll take a quick break, but please remember to return for the next meeting. It will be the same link. And thank you again to all our committee members for attending this portion of the meeting today. I look forward to seeing you at the next meeting.